very good morning, and thank you so much for the invitation to the BC team, and it's a real honor to be here. Coming from Belgium to Canada, we feel connected, certainly in this period of what the world is going through. And I want to talk to you about quality of care, of course, but also to share you some stories of myself to make the human connection. As Christina already explained, I'm a professor at Leuven University. I lead a team of talented people doing research on quality of care, care processes, and person-centered care. I work part-time in a large academic medical center and doing some work for the government. But if you have the privilege to visit my country, and you have a beautiful country, but this is Leuven, very old town, a university city, and I hope that you know this city because of our university, and we celebrate our 600th year anniversary this year of the university, but I know that you don't know Leuven because of this, but I think that you will know Leuven because of this. Yeah, that's it, yeah. They also have a 0.0% right now. That will be important. But this is front office right now. I have the privilege to explain you what we are working on, but in every front office there is an important back office. And this is the back office. These are the people doing the work. These are the people doing the research, the PhD students who deliver the data, who deliver the papers. So a very special thank you for them, for all the work that they are doing back home. But let's talk about quality, and let's first start with reminding you about the actual numbers about quality and patient safety. And if we look at the recently published Global Patient Safety Report 2024 by the WHO, there is still room for improvement. There is still a challenge. The challenge is that in this report, it was for the first time published that more than 10% of patients in hospitals have adverse events. Until 2018 report, we were talking about maybe 10%. Nowadays, we are talking about more than 10%, and 7% in primary care. So for the patients and kin, it's hugely important the work that we have to do and the challenges that we have, but also for our governments and for our policymakers and for our funders, because in the same report it is mentioned that the cost of poor quality is 12.6% of our hospital expenditure worldwide in high-income countries. So let us not misunderstand that. And we have been working, and all of us, also in Belgium, also in Canada, you've been working on quality of care, but a few years ago I had the privilege to collaborate with Paul Betelden and with Peter Lackman, and I met Ross yesterday and we were talking about Paul, and Paul explained as well there are some waves in healthcare management and in quality management. And years ago we worked on what he called and what we published in the paper as Quality 1.0. Quality 1.0 is about thresholds, and we use guidelines, standards, inspection and accreditation, and certificates, and you had quality or no quality, a label or no label. But that's not enough. We have to go a level higher, and that's Quality 2.0. Quality 2.0 is about organization-wide systems. It's about care processes and pathways. It's about system. It's about reliability 24/7, 365. It's about performance measures. And we have been trying with those two, Quality 1.0, the basics, and Quality 2.0, the systems. We hope that we would solve the problem. But if we look at the data, at the more than 10% on the one hand and the 12.6% on the other hand, this isn't working, or it's not enough. So we think that we have to go towards Quality 3.0. And Quality 3.0 is about co-production of health. Looking back and thinking back about service that we provide. Not only the excellent technical care, but also the service. It's about ownership of health. It's about co-production with patients, kin, and providers, and it's about value creation. But as this lecture is about the human connection, I want to share with you a short story. And once upon a time, in a hospital far, far away. And I go back to June 5, 2021, when I was admitted to a large academic medical center as a patient. I was 47 at that time. It was a Saturday evening, June 5, 8 p.m. And I had heavy acute abdominal pain radiating to the back. My medical history was okay, nothing worse. I had some kidney stones. And that evening I thought, oh no, again, I have kidney stones. And I was admitted to a hospital where I work. I say no names. 1,500 beds, large academic medical center, 4 times international accreditation label, 70 different quality labels. So I thought everything will be okay. And I was admitted, and I met a junior doctor, and he told me, I want to have a CT scan. And I said, midnight. Yeah, you have to drink for the CT. And I said, but I have kidney stones. I don't want to drink right now. He said, no, I don't think that you have kidney stones. I'm thinking about something else. And we did a CT. And the CT showed that I had no kidney stones, but he gave me another diagnosis. I had an acute, severe pancreatitis. And it was painful, more painful than kidney stones, I can assure you. But why was it? We don't know. I had no food, only IV drops, and I can tell you that prednisone is good stuff. But every day, a medical doctor came to me, and I remember the question that she asked me. On day 1, on day 2, on day 3, she asked me, how many units do you drink? And I said, 3 to 5. And she asked me, per day? I said, no, per week. And she laughed, she smiled. And the second day she came back and she asked me the same question again. I said, 3 to 5. And she said, but per day? I said, no. And the third day, the same question again. But her supervisor was with her. And I know the supervisor. He told me, Kris, it's normal that we ask you that question because 40% is alcohol related. And we don't know. And we have no signs, your ultrasound, we have no signs that it's another reason. I told him, but it will not be alcohol related, I'm sure. Well, then there is only one option. We have to do an endoscopic ultrasound of your gallbladder. And so we performed the ultrasound of the gallbladder. And it showed that it was not a black hole, but it was microlithiasis. And in the report of the radiology was mentioned, it looked like a sky full of stars. And so I had a sky full of stars. Nothing to do with the Coldplay song that you heard, but this is another reason. I was, on the one hand, very happy because it was a non-alcoholic pancreatitis. But I needed surgery. I needed a laparoscopic cholecystectomy. And when I woke up, some minutes after I woke up in my room, I received a message on my phone because on my phone I can dig into my electronic patient record. And there was a new message. And there was new material. And I opened it. And the first thing that I saw after I woke up was this. I said, wow, what have they done? And some minutes later, the surgeon came to me and I asked him, how was the surgery? And he said, wow, Kris, done in 15 minutes, piece of cake. It's like riding a bike. And I asked him, is it okay? Oh yeah, and Kris, you know, I did it especially for you. It was 2 years ago that I've done it, because normally my junior fellows perform this organization. And I was thinking, oh my God, all my research on volume and outcomes. But they gave me a survey a few days later. What is the overall score of the hospital, and what do you recommend the score? And I gave the hospital an 8 out of 10, and I said, very sure I will recommend the hospital to my kin, to my family members, to my friends. But the director of quality asked me, Kris, is there room for improvement? And what they did not know was that during my stay, I've sent messages to myself on Messenger, and I have a recording, or I have details about all the details. What I heard, what I saw, what I smelled, and I made a report for the CEO of the hospital about it. For example, I wasn't a mystery patient. They knew that I was one of the quality managers in the hospital. And they also told me, you know, our head nurse is a former student of you. Oh yeah, I can imagine. So they knew. But I saw some things. I saw unclean hands. I saw information for the patient that was really outdated. 24/7 videos on a television in the room with information that was outdated. On my cell phone, I could see my MRI scans. I even could ask questions on the MRI scan on my cell phone. And then when I went to my doctor and I said, can you answer my questions? He said, well, what are the questions? Well, I wrote you, oh, there is no connection between your cell phone and the electronic. It's toys for boys. Interesting. But also some other things. When I had a problem with my IV, and I asked, well, can you fix it? The nurse told me, was it my colleague of this morning who did it like that? Oh no. That gave me a very unsafe feeling. And even I checked some things. 10 times a day they ask you for your name and your date of birth. And then they check it that they've checked it. And 4 times I gave a wrong date of birth. And they checked the box, but they didn't listen. Even just before my OR, where the anesthesiologist told me, hey, Kris, it's me. I'm a former student of you. And then I said the wrong date of birth, and she didn't notice. So I was thinking, what are we doing? How are we taking care? And these are technical things, but the thing is about the human connection. The human connection is how we treat patients, like in the morning, yeah, or welcoming you in the hospital with your cell phone number. These type of things. This is about the human connection. This is what we have to do. This is what we have to think about if we want to go to quality 3.0. And quality 3.0 is that we have to take in mind, or we have to ask the question, is quality in 2025 more than the 6 dimensions of the Institute of Medicine that date back from 2001? And these are still the 6 dimensions that are mostly used in publications worldwide. Safe, effective, efficient, timely, person-centered, and equitable. But may I ask you one question? Where were you back in 2001? Where were you in your career in 2001? Didn't the world change? Why are we still using models of 24 years ago that are highly cited in literature? And together with Paul and Peter, we published a paper a few years ago, Open Access in F1000 Research, on a multidimensional quality model. And 2 years ago, we translated that model into what we call the House of Trust. And that is the model that we are using right now in our hospitals, in 25 hospitals, to collaborate on quality from a multidimensional point of view, with a front office and a back office, with the context in mind. But we know, and then the first thing is that quality takes place during what we call the moment of truth. And that is what a patient understands. That is what I understood during my admission to hospital. And the moment of truth is defined by what we call 4 core values of care. Dignity and respect. Dignity and respect, like the opening session. Dignity and respect. Holistic. I can give you one short example of non-holistic care. Once I called the nurse because of my medication, and I heard them saying, the pancreas calls. But this is the way that we talk about patients. But we are not aware that the patient hears it. It's about partnership and co-production. It's about empathy and kindness, like the video that Christina made for your colleague. She didn't have to do that, but that was kindness and compassion. That was about empathy. These are the important things. But of course, it's only possible to do this if your back office is okay. This means your protocol, your pathways, your procedures, and they have to be based on the fundamentals, on safely, on diversity, on effective, on timely, on eco-friendly, and on efficient care. And we will need the managers and the supporting staff in the blue in this model. They need to focus on transparency, on communication, on leadership and resilience, both for patients, for kin, and for healthcare professionals and providers. And only if all those rooms of the house are okay, then we can come to person-centered care for patients, kin, professionals, and providers. And yes, the government can do inspection on the back office, but in the front office, we have to take the challenge and we have to take our responsibility to measure it day by day, 24/7, without any labels and without any other things. The front office, that's our work. We have to be proud about it. And based on this model, 25 Flemish hospitals, we have in Belgium 100 hospitals, 11 million inhabitants. In the Flemish part of the country, about 55 hospitals, and 25 hospitals, they made together, under the lead of Leuven University, we want to build a new quality management system. And in a co-production and co-design, they want to they will develop this new model of quality, a quality management system. And we called it Flanders Quality Model, FLACM, towards sustainable quality of care. And sustainability has got nothing to do here with eco-friendly, but a sustainable way, a sustainable system that it's really integrated. And the FLACM model consists of 3 different pillars. First, we have to focus on the quality vision. It's about thinking. We do that based on our house of trust, but also making it happen in real care. That's quality co-creation. Do. And it's like Helen Bevan was telling yesterday, it's not about expertise, but it's about exploration. We have to explore, we have to learn, we have to innovate, and that is the reason why we do it in collaboration with hospitals and with the university. So how do we make that in practice? How do we do that? Well, the thinking we do by measuring based on data, not only focus groups and brainstorm sessions, but based on data. And we have developed validated scales for that, like our FLACM Quick Scan, and of course we use hard data. The FLACM Quick Scan is an instrument that was developed in the PhD of Ian Claessens, and you can read about it in the BMC or in the New England Journal of Medicine Catalyst, where we explain that we have developed a new instrument, 18 questions on the different aspects of the House of Trust. And so we have 2 parts of the instrument. One part is about those different rooms or dimensions on patient care. But we have a part B, and that is on care for providers. And we ask patients, kin, and providers to score both. So we also receive information about how patients and kin think that the hospital or the rehabilitation center is taking care of the workforce. It's interesting to have those mirror data. And if we look, for example, at the data from what patients are telling about patient care, well, these are some numbers. And the green means that they give an 8 out of 10 or higher. But look also, for some of the dimensions, there is a lot of room for improvement. Only for some of them, more than 75% have top scores. And during the workshop in the afternoon, we will go in detail to those data. And these are the data of patients about patient care. But if I would show you the data from the workforce about care for the workforce, these are the numbers, based on nearly 11,000 surveys out of these hospitals. So this type of feedback, where hospitals receive feedback on unit level and on hospital level and benchmarking, helps them in thinking again about what quality really means for them, not just checking the boxes, but really why they stand for. They want to be proud. But of course, we do not only use these type of data, we also use hard quality indicators, like hospital standardized mortality ratios. This is Belgium. This is Belgium. This is the variation in hospital standardized mortality in Belgium, going from the worst hospital with an HSMR of 1.45 to the best hospital with 0.61 HSMR. So I think a huge difference. In a small country, 11 million inhabitants, 100 hospitals. And one of my PhD students, Astrid, did her PhD on these type of data, and what we found, if we look at, we try to understand why there was a difference. At this moment, we don't know why there is that difference. The difference is not defined by region, nor by teaching status, nor by number of beds, and even not by accreditation. There are hospitals with accreditation label in the red side, in the blue side, in the green side. So we are really wondering, how can we improve the quality of care? And do we have to do it on hospital level or on patient group level? And if we look at data on patient group level, what you see here in the columns are hospitals, and in the rows are diseases, the major diagnostic categories, the MDCs. And you see the variation in mortality. Green means you're in the 25 top hospitals with the lowest mortality. Red means you're in the hospitals with the worst mortality, the highest mortality. But look, there are some hospitals who do really good on more than 75% of all the diseases, but we have some hospitals that are doing for the major part of the diseases worst, in the worst group, in the P75. And if we look at the data and we try to understand why there is a difference, also there we cannot find the indicators. It's not about region, it's not about teaching status, it's not about number of beds, it's not about accreditations. So we have to dig in deeper. But these data help clinicians and C-suite members of the organizations in thinking about quality. But of course, we have to make it happen. We have to do it. Quality management systems. So what we do is we try to build we need a sustainable implementation based on what we call multi-stakeholder co-creation. It sounds interesting, multi-stakeholder co-creation. But what it means is that with our PhD students, we have developed a roadmap for hospitals how to do that. It's a driver diagram with 6 drivers. Based on the first 3 drivers are Durand's trilogy. It's about design, control, improve. But that's not good enough, only Durand's trilogy. We have to build further on. So we have included quality leadership, quality culture, and taking the context into account. And what I learned the last few days here in Vancouver of a lot of people, and Andrew explained me yesterday in detail how diverse the country and the provinces and the rural areas. If I talk in my country about rural areas, it's half an hour driving. Andrew was telling me, Kris, there is a difference. Without any traffic jam, you're from the south to the north of the whole country in 3 hours. But we have that variation. So there is something wrong. So we have to help them in developing and implementing quality again. And based on these 6 drivers, we have developed 19 building blocks that you can see. And you have to read the drive diagram from the bottom up to the top in 19 different stages. And that is what we explain to C-suite members, to clinicians, to managers. But to the quality management team, we have developed for each of these building blocks action fields. In total, 104 action fields based on evidence. Every of those action fields are supported by at least 3 recent papers. So it's an evidence-based, the content of the model is evidence-based, and there's nothing new in there for you. You will recognize everything, but we have tried to combine the most interesting parts together. And so in helping, and this is open access available in papers. So a lot of companies don't understand why do you publish it open access? Because we're a university. So you can read it, you can read about it, and we will come back to that in the afternoon. But together with the hospital, in co-design, the hospitals created based on these action fields and building blocks, a maturity model to self-evaluate their quality management system in a 19x5 maturity matrix. And I will not go in detail, but all these cells are blank right now, but they are filled with words and what you have to accomplish before your flacum level +1, for example. And if I show you the variation on these self-evaluation for the first 20 organizations done 2 years ago, this is what they gave. The white ones, N and F, means not yet flacum level. But look at the variation. And look at the variation. What I felt surprising was that all of these hospitals have been working for years on quality 1.0 and 2.0. But if they do a self-evaluation of their quality management system, there is room for improvement. And some of these hospitals told us, well, maybe we scored a bit too high. And some of these hospitals told us, well, maybe we scored a bit too low because we want to improve. But even if you're in the middle, we have to think about that there is a difference between Q1, Q2, and Q3. If we want to have sustainable quality management systems, we have to go towards quality level 3. So we have to explore, we have to learn, we have to think about it. We really have to understand what quality is all about. And so we need research. It's not because we are a university, but if we do not understand right now why there is that variation, then maybe we are spending a lot of efforts and a lot of resources on things, on projects that do not add value for the patients and kin, and maybe ask a lot of energy from the workforce that does not make them happy. And we heard this morning that we have to have fun. So it's not funny to work on quality if it doesn't improve our care. So that's why we bring people together. And what I can tell you, although that I have a brilliant team of researchers, and they are very talented people, we cannot do it on our own. That's why together with these hospitals, we have built what we call the Flacum Consortium to learn from each other. They share a lot of expertise and experience with each other. And for example, during our learning and innovation sessions, every month, it's a small country, it has some advantages, they meet each other live. Yeah. 1 month live, 1 month online, 1 month live, 1 month online. And they share expertise, they share experiences, they share how they are using the quick scan data, they share why they think they're on building block 4 on Flacum +2 and they want to go to +3. How can we do that? These things are important. Monthly knowledge sharing, but also a lot of teaching. I found it very surprising that a lot of people are enthusiastic about the House of Trust. I don't understand it. It's so normal. Why are we enthusiastic? But if we talk, for example, with clinicians, certainly with medical doctors also, they say, but this is why I've chosen to work in healthcare, because of the core values. I could have been, one of my friends is a trauma surgeon and told me, I could have been an F-16 pilot. But because of the core values, Kris, I've chosen for healthcare. So we have to bring that quality 3.0 service level again attention. And it's not only about soft things. Quality 3.0 means also that your safety standards are okay, that they don't accept when I say a wrong date of birth and that they notice it. It's not only about kindness. So we have to do a lot of teaching about it, a lot of workshops, more than 400 clinicians and managers were trained. And very interesting, right now, today, my colleagues are doing what we call a Flacum challenge. It's external peer review, external audit. We are not so, in one of the hospitals today, there is a group of 8 people, 2 of my fellows, and 6 other people, CEO, CMO, quality managers, visiting one hospital, and based on the maturity matrix, on the data of the quick scan, on the data of the HSMR and the other patient safety indicators, they do an audit by visiting the management team, visiting wards. They are not checking the medication, they are not doing closed record reviews, but they are asking, tell us how you work with quality, what you do, what is positive here, what is negative here. And after one day, it's surprising that we find some challenges. And we do not provide an audit report, we provide a challenge report. And within 6 months, they have to build a plan to work on these challenges. But as we are explorers and we want to understand why it is working and why it is happening, or where we have to focus on, we have to understand how quality is working. And although there is what is the impact of the team? What is the impact of the organization? Is the background of your CEO important? Is it important that he is a clinician or an economist? Would there be a difference? What about the psychological safety in the team? Can you ask the stupid question or not? Do you feel safe? What do patients say? So what we are launching right now, and the first hospitals will start measuring in a few weeks' time, is this whole study. It looks complicated, but it's simple. You will understand. It's about understanding what has an impact on the green box, the final outcomes. And the final outcomes we are measuring by measuring quick scan data, so perceived quality, but also hard data, mortality, indicators, patient safety indicators, length of stay, readmission rates. We will look at financial situation of the organization. We will look at patient satisfaction score. We will look at reputation scores. Is there a link between outcomes and the reputation of Newsweek Top 250 that was published 2 weeks ago? I have no idea. Well, my hospital says yes, of course, because we're number 40 worldwide, but I'm not sure. Why is it? Is there a link? So we want to understand the green parts. But if we want to understand the green part and we want to understand the variation, we will have to look also at the other building, at the other blocks, like measuring the context. My research fellows are working very hard. They are interviewing all the hospitals at the moment to understand the context of the organization. How does the management team work? What do you have? What are the resources? Qualitative data. But we also will measure what we call the mechanism in red, in orange. The quality management system. And of course, we have validated scales for that. We have the maturity matrix, for example, that we will be able to measure. And we have a co-creation scan that is also published to measure the maturity of the quality management system on team level. And then we think that the most important box of these 4 is the yellow one. Although that we tried over the past years to focus quality again on C-suite level and convince managers of investing in quality, I don't say that we did the wrong thing, but I think we underestimated, and I'm very honest right now, we underestimated the value of the teams. That's where it happens, that's where it works. And for example, we will measure on team level psychological safety, team culture, and team leadership. And last year I had the privilege to talk about that with Amy Edmondson. And you know Amy's work on psychological safety. And we said we will measure these things, but what is a team? What is a group? What is the level that we have to focus on? And Amy told me, it's easy, Kris. The team, the group, is the level where it happens, where the action happens. I think she meant where the shit happens. That's where we have to focus on. We have to focus again and use these mechanisms, these models, this house of trust, but also this maturity matrix, the quality management system, also on team level. And so we hope to have data from 40 hospitals, 400 teams. We hope to have more than 10,000 individuals, patients, kin, and provider outcomes to try to understand the relation between and within those blocks. And maybe then, afterwards, we can focus on real interventions within these different hospitals. So if I look back what we are doing, I think there are some challenges. And the challenges that we have are, for me, threefold. I think the challenge, if I go back to the discussions that I had with my mentor, Peter Lackman, and with Paul Batalden, then we have to focus on three different things. The first thing is that we have to convince each other and convince our clinicians, but also our managers and involve patients and kin that quality is multidimensional. It's not only about checking the boxes, although that it is important, but that it's multidimensional, front office and back office. It's about the moment of truth. It's about dignity and respect, holistic, partnership co-production, empathy and kindness. It's about transparency. It's about communication, leadership and resilience. But it's also about the heart indicates we have to combine both worlds, front office and back office, with the multidimensional model. Second challenge that we see, and when I hear and the different conversations I had yesterday and the day before also with some of you, is that you also recognize that it's multi-stakeholder. It's not only about patients and kin, but it's also about professionals and providers. We have to combine both worlds. And the third thing, the third challenge that we have is the multi-level. It's going from the individual over the clinical microsystem to the ward and on organizational level, and we will have to focus on quality for that. But let's not underestimate that challenge and also that last challenge on clinical microsystem. And a few months ago, I had a discussion with the CMO of my hospital, and he's a gastroenterologist. And he was asking, Kris, how are you? How's the pancreas? I said, okay. We learned a lot from it, yes. And I asked him, I want to do an additional thing. Can you give me permission that I ask a log of my electronic patient records of that period when I was a patient? And so I was interested in finding out how many experts from different backgrounds were involved in taking care of that one not so easy patient. And so what we did is we measured from June 6, and you know that June 6 is What Matters to You Day. I was admitted on What Matters to You Day. Can you imagine? Yeah. Until September 23, when I had my last scan. Well, not my last scan, but that period. So over 4 months' time. And I think we underestimate. And I know that we have to take here into account differences between large academic medical centers, like in this hospital, it's a 1,500 hospital, yeah. Lots of disadvantages, and it will be different when you're in a rural area. But if I look how many people took care of me, and not just by having a look in my electronic patient record, but adding information, I was impressed. What you see here is everyone is one unique person during that day. So during my admission, my first 24 hours in emergency department, 35 different individuals created value or did something. If it was value creation, I don't know. I don't know. In the front and in the back office together. In total, when you would add up these numbers and you would look at unique number of persons, there were 133 different unique persons out of 15 different professional groups that took care of me. About 40 of them in the back office, administration, organization, coordination. These things are important. I underestimated how many people took care of that one not so easy patient who took notes of every detail because he had nothing to do than to watch Netflix and listen and hear what they were talking about. And if I can give you one suggestion, and I promise myself that every time when I have the opportunity, I will show the picture that I took. And I hope that it will remind you when you take care of your next patient. May I please remind you that also here behind the curtains, a lot of work is done. But do you really know that this type of curtain is only a visual barrier? Audio is... Do you know what we hear as patients? The gossip or the things that you're talking about the head nurse or your colleague or your holiday or what you're making for food or the medical doctor, they're not coming for their round. Yeah. Or talking about a patient, he's a drinker. I know that type of patients. They all say they only drink 3 to 5 units. He's a drinker. Just behind. So they close the curtain. He's a drinker. I'm at the moment the biggest fan of 0.0 beer, and as a Belgian, that's a huge challenge, I can tell you. But I was not a drinker. But I take no risks anymore. But although we found a lot of things to improve, there were also some great things that I experienced. And a few years ago, we came up with a word for that, and we call it small acts of kindness and leadership that clinicians show. And if you have the time in the next days, take a look at the website mangomoment.org. It's about small acts of kindness. I was surprised how it touched me to have visitors. Some of my colleagues, every morning at 7 a.m., a surgeon came to visit me, coffee in his hand for him. But he just came around. I was not his patient. I was even not on his ward, but every morning he came to say hello. Every noon, another guy came to me to say, hey, how are you? That was the moment when I cried. I felt safe. When he asked me, are you in pain? And maybe I said, no. To him, I said, yes. And to be honest, every day, my director of quality came by. And he knew that I was taking notes. And every day, he asked me, tell me your story. And so we have improved some things based on the one unique patient story. But I will never forget how I looked forward to meeting the lady of the cleaning department every noon about 1:30. That was the only person a day that you meet that do not ask questions about pain, lab, but it's just small talk. I did not need prednisone at that moment. That was about kindness, empathy, compassion, about core values. I love to receive flowers. I never received, well, for a lecture or something, but really impressive. And nowadays when I'm in the hospital and I see the lady or man of the flower shop walking with flowers, sometimes say, hey, do you know how an important role you have in our hospital? And then they look at me and they say, psychiatry. But no, I mean it. And I say, I've been a patient. Do not underestimate your role. You're an important part in the whole chain. And I will never, ever forget that beautiful nurse. And at one moment, one of my research fellows was visiting me, and I can tell you, he's handsome. He's good looking. And 1 minute later, that young nurse came by. Kris, who was that? And I asked her, why are you so interested? Is he a medical doctor? Yeah. Of our wards? No. What is his name? No. These are the moments. I will never forget the hands. I will never forget the negative things. But I will always remember the great work that all our colleagues are doing 24/7, 365 in every country, every day. And we owe them a big thank you.